We've known for a long time that the majority of head and neck tumours, up to 90% of tumours, will overexpress epidermal growth factor receptor, and we know that there are agents that act against that target and that enhance the effect of radiation. So for instance, cetuximab has data in a positive phase 3 trial. We know also that head and neck cancers overexpress other members of the HER family, and one of those is HER2, CERB2, and so we've identified the potential of using a drug that specifically targets both EGFR and HER2 at the same time as a good combination strategy with radiation and chemotherapy in head and neck cancer. We conducted initially a phase 1 study to show safety and tolerability of Lapatinib during full-dose chemoradiation. So we treated patients with stage 3 and 4 head and neck cancer with concomitant cisplatin-based chemotherapy and radiation therapy. We showed no limitation to the dose that we could deliver, so we were able to give the target dose of 1,500 milligrams a day of Lapatinib. That was the phase 1 trial. Subsequently, we did a window of opportunity study in which we randomly allocated patients 2-to-1 to either Lapatinib or placebo, 107 patients, and we took tissue before and after treatment in this window period, and we showed that Lapatinib reduced significantly the proliferation of tumor cells in comparison to the placebo group. We subsequently conducted a randomized phase 2 study of Lapatinib against placebo in patients with stage 3 and 4 head and neck cancer during radical chemoradiation. And the signal from that study was that in an HPV negative population, there appeared to be a strong trend towards a better complete remission rate and disease-free survival rate. In the phase 3 study, we wanted to test the hypothesis that Lapatinib, in combination with cisplatin-based chemoradiation, would improve the disease-free survival in a population of patients treated surgically with stage 2, 3 and 4 head and neck cancer. And those patients would be identified as having features that would be indicative of a high risk of recurrence of their disease. So specifically, close or involved resection margins, R1 or R2 resection, and the presence of extracapsular spread in the lymph nodes. This trial was successfully recruited. It recruited between February 2007 and June 2011. We had targeted originally that we would see 298 events in order to be able to declare whether or not we had met our primary endpoint. We saw at the end of 2012 that the event rate had plateaued, so we actually discontinued that disease-free survival follow-up, and we analyzed the data, and we unfortunately have demonstrated actually that there was no benefit to the addition of Lapatinib to chemoradiation relative to the control group. The context that we're testing Lapatinib in this phase 3 study is in a postoperative setting, whereas the original phase 1 and the phase 2 data were based upon tumor in situ with radical chemoradiation of the gross disease. And so there is still, on the basis of the fact that those data had suggested maybe that there was a signal in HPV negative disease, that is something that's still worth testing, and there is an RTOG study, the so-called TRIHARD study, which is targeting specifically HPV negative disease. In the setting of the postoperative patient, even with high-risk features, Lapatinib apparently does not add anything to cisplatin-based chemoradiation. Yes, we powered the study based upon historical data from the RTOG 9501 study published by Dr. Cooper and colleagues, and we were projecting that we would hopefully achieve a 10% improvement in disease-free survival from 55% to 65%, and we did that analysis at the 2-year time point. What happened, in fact, was that in both the control arm and in the Lapatinib arm, the chemoradiation was significantly better than that historical population from the Cooper study. Clearly, we have to recognize that those two populations of patients in the Cooper study and in our study may not be exactly the same, but nonetheless, in a 10-year period, we've seen that the performance of a postoperative chemoradiotherapy regimen looks better than an historical control population. The clinical implication, and the most important clinical implication, is that there is no role for Lapatinib in addition to chemoradiation in a postoperative population of patients with high-risk head and neck cancer. I think we've seen that in trying to do these studies where the drug was given not just during the chemoradiotherapy but for a maintenance period of 12 months, this raises some issues about some ongoing strategies relating to the use of maintenance therapy. So there are ongoing studies looking at drugs such as Afatinib, which is a pan-HER inhibitor. It's a different trial design in their study because it's a population of patients who have received radical chemoradiation. It's not a post-operative population, but I guess it raises some questions about the strategy of using HER2 blockade in this context, in an adjuvant setting. In the setting of head and neck cancer, one of the things that we have learned, what we've known for the last decade, is that although we know that, for instance, EGFR is of prognostic significance, the expression of EGFR on the surface of cancer cells is not a predictive biomarker for selection of patients for targeting strategies, for instance, with cetuximab or with small molecule tyrosine kinase inhibitors that hit the HER pathways. So one of the difficulties we have in this area is that we don't have a clear predictive biomarker that tells us which patients we should select for anti-EGFR or anti-HER therapeutics. Well, from this study, they should take the view that the use of Lapatinib in patients with head and neck cancer remains investigational. There is no indication that this drug is going to be put forwards for licensing because in this current study it hasn't worked. There is an ongoing RTOG study in HPV-negative disease, and we will await the result of that phase 2 study to see whether or not Lapatinib has any future in the treatment of patients with head and neck cancer.